You know, what's interesting. Oh, there we go. I can see
Yeah.
participants coming in now. Welcome, welcome. We'll be getting started here in just a few minutes. Thank you for waiting, everybody. We had almost 1,000 people again registered for this event. So everybody's going to be coming in. We're super excited about doing this for you guys. We'll try to start right at 6:30 Central Time, wherever you're joining us from today. I know it's 4:30 for you. And with daylight savings time this weekend, it was dark. I was kind of doing a bunch of things and heads down working. I looked up and I saw how dark it was outside. I thought, oh my gosh, did I miss my webinar? Because I wasn't used to the change there.
I definitely had an alarm set.
Yeah, I had to do that too. I don't trust myself because I get tunnel vision and focused on things from time to time. And so there you go. So people are jumping in. Good. So we'll be starting in just probably 1 minute and 30 seconds. If you guys can hear us, could somebody give me a little message here in our chat box? If you have the ability to just open up a chat and say, yes, we can hear you. And I see a hand raised. Okay, I'm getting hand raised. Perfect. Thank you so much. I appreciate it. Outstanding. So excited to do this. This is kind of a little bit new for us. Oh, chat is disabled. Well, that's a little annoying. Maybe I could take this 1 minute that I have. Actually, I probably can't enable it. Because last time I tried to edit while I was in the webinar, it didn't take my edit. But give it a go.
You can try it. Yeah, that's Bretta is one of my team members, and Carissa said test for Q&A box. Carissa, can you verify if you're logged in as a participant? Well, okay. Brenda just said hi.
Oh, we did get a text from her, a message.
Carissa, Q&A box is working. Yes, she's logged in. Yes, they're coming in. I think you fixed it.
Okay. All right. Super cool. All right. Well, let's go ahead and get started then, because that's what we're here for, to start this thing. So welcome, everybody. I'm sure people will be jumping in as we go, as happens. Listen, I wanted to go ahead and tell you guys how excited we are. We are doing this webinar this evening at your request. So we had on Dr. Doug Lucas about a month ago, and we talked about a number of things. We talked about his book that was coming out. We talked about, you're really what we're doing at Osteostrong and the science behind that. And within the knowledge base of Dr. Lucas is his understanding. He has a deep understanding of hormones and supplementations and ways to affect bone health. And everybody thought that was really valuable, as do I. And certainly we want to make sure you guys have the best information possible. And so I'm always talking to experts around the world, researchers and this kind of thing. And we really just want to start making all this information available to you. And one of the exciting things that's really come out of these relationships is not only an opportunity to do things like this, but also we have an opportunity to write a book together. And I mentioned it last time we did this back in October, where Dr. Lucas and I are writing a book together. So there are a couple of large research projects that Osteostrong has funded around how Osteostrong affects the human body, specific to bone density, balance, strength, HbA1c, which is your long-term blood glucose marker. And then many of you have experienced these types of effects by coming to Osteostrong. And so the research surrounding that is pretty exciting and compelling. And so we can't publicly share any of that information until it publishes, but we're writing the book around that information. As soon as it drops and we can include the information in the book, so you guys will get it. We'll have one of these webinars to tell everybody about it. We're really excited, and then we'll go on the whole book tour thing and get it out there for you. But for those of you who weren't on the previous call and didn't get a chance to really get to know who Dr. Doug Lucas is, you can see his sign, the Dr. Doug, in the background there. So you can, I guess that's an invitation to call him Dr. Doug. He is a double board certified physician He is an orthopedic surgeon. He is he left the traditional medical system to really focus on optimizing human health. In fact, he started a company, Optimal Human Health MD and Optimal Bone Health MD. He is a believer in what we do here at Osteostrong, and he has also formed a professional relationship with Dr. John Jaquish, who is, of course, the inventor behind the devices we use at Osteostrong that deliver these amazing results. So this particular webinar is in regards to a lot of questions that we had on the first webinar, and simply there wasn't enough time to go into a deep dive. And I find it quite valuable, and I thought you all might as well. Specifically, Dr. Lucas is going to be speaking about hormones and their effect on bone and the rest of your health, and it's one of his specialties. So I want to thank you, Dr. Doug, for coming on and making yourself available for this webinar. I think everybody's really looking forward to it, so thank you so much.
Yeah, thank you, Kyle. And that was a really nice introduction. I really appreciate that. Before I get started, I did just want to make a notice that it looks like the Q&A box is working. So for people that are trying to use chat and it's not working, feel free to put questions in the Q&A as we go. Both Kyle and I have team members who are in there who are going to collect some questions, and we should have plenty of time to get to questions at the end. So just so that's out there. Before I share my screen, and we're going to go through a presentation that I have on this, I would just love to say about this topic of hormones that it is one of the most controversial things that I talk about, because there's so much confusion. There's so much fear around hormones, and there's so many challenges around talking to your doctor, your medical team, even your neighbor about hormones. It kind of falls into that same category of religion, politics, and nutrition.
We're going to add another one: nutrition, yeah, politics, and hormones.
These things I love talking about. So with that said, know that the additional training that I did, as Kyle mentioned, I left the traditional medical model and I went through a fellowship with a group called A4M, and that stands for the American Academy of Anti-Aging Medicine. One of the primary things that they do is to educate people on hormone replacement, hormone optimization, if you're not a candidate for replacement, the ins and the outs, the risks and the benefits. And what was most valuable for me in that education was digging into the research that really stimulated a lot of the fear. So understanding the history behind it, understanding the research that provoked the fear, and then the response as a result of it. And that's really what I want to go through today. So let me share my screen. This worked before. It should work again. All right. Kyle, can you see the screen that says hormone replacement and bone health? Perfect. Okay, great. All right. So as I said, we're talking about hormones, and one of the arguably most important topics that we could talk about when it comes to bone health. There are a lot of tools, as we talked about last time. There are so many different things that you can do, all having variable benefit, but hormones are a big player if you're a candidate for being able to utilize them. Quick medical disclaimer, which is I can't create a patient-physician relationship through this platform. That means that I can't tell you what you should do. So any recommendations, especially on these topics, you need to talk to your own medical team about that. So this is what we're going to go through. We are going to talk about, again, why doctors don't talk about hormones unless they have to. We're going to discuss the different sex hormones. This is going to be primarily focused on hormones for women, although I will touch on this a little bit with hormone optimization and replacement for men. Again, risks, the benefit conversation, and then what I really want to impart to you is the questions to ask your medical team coming out of this. Yes, I have a practice, but that's not what I'm here to do. I'm not here to sell. I'm here to educate. So I want you to take away from this what you can use to then optimize your own plan, your own treatment plan for your bone health, and ultimately for your health span. And again, we'll leave time for Q&A at the end. And for those questions, again, just put them in the Q&A box. And both Kyle and I have a team member who is waiting and writing them down. All right. So you guys probably all know this about hip fractures, but as an orthopedic surgeon, this was what I hated to see. The people that would come in with a hip fracture, particularly if they didn't know that they had poor bone quality, because the outcomes are pretty bleak, with about a third of patients either not making it to the year mark, a third of patients losing independence completely, and then a third of patients, quote unquote, regaining independence. But what they mean by independence in the literature is not really what you think about independence for the most part. Rarely did I see somebody suffer a hip fracture and get back to the life that they were living. I can think of a few, and they really stood out to me. And that's out of hundreds of patients. Not only just hip fractures, but also the death rate as we age. All of us want to live as well as we can for as long as we can. And you can see that the number 4 cause of death over people age 65 in the United States is from falls for the most part. It's actually accidental deaths, but falls becomes the biggest part of this as we age. And you could look at that yellow bar there and say, oh, well, I'm not as worried about 85 and older if I'm in my 40s, 50s, and 60s. But the truth is, to avoid that fall in your 80s or 70s or 60s, you need to start on this in your 30s, 40s, and 50s. I think I can skip my introduction. I think Kyle did a great job. I don't really have a whole lot else to add here other than the platforms that we created in Optimal Human Health and Optimal Bone Health really try to create a comprehensive program to help treat whatever it is, whether it be bone health, whether it be health span in general, trying to live better longer. And I'm going to show a little bit of this framework as we go, and not because I think that everybody should do this with their doctor, but I think that everybody should look at their own health through the same lens. In other words, as we try to optimize our health, we need to start at the foundation, and that's the lifestyle stuff. Hormone replacement is part of this framework that we use, but it's not at the bottom. And so we'll talk about hormone replacement, but it is 3 tiers up in our framework after talking about all of the lifestyle stuff, all of the potential targeted biomarker driven supplementation, and then we talk about hormones. Osteostrong lives in the foundation of that. So that stimulus has to be there. Yes, you can see improvement in bone mineral density and reduce fracture risk with hormones alone, but what you'll see in the literature is it's marginal, it's small. It is a tool, but it should not be your only tool. The reason why hormones are something to talk about is that osteoporosis, while most people think, ooh, DEXA score, T-score, what's my bone density? The way we look at osteoporosis is an imbalance of bone metabolism. So we are always turning over bone throughout our life. When we're in our adolescence and early adulthood, we are building more bone than we're breaking down. As we get into our 30s and 40s, hopefully it's balanced, although usually at that point, most people are losing bone. And then as you age, you start to lose more bone than you grow. That's the traditional pathway of bone metabolism. Our goal is to keep it flat, and arguably we can continue to add bone if we provide the right stimulus and resources to your bone. But osteoporosis is simply that imbalance of metabolism. So yes, T-score is a thing, and yes, DEXA is a tool. And we talked about that a lot last time. I won't go into it now, but know that really what we want to do is we want to correct that metabolic imbalance of bone. So let's talk about doctor school. I never want to disparage my fellow doctors because I think the vast majority of doctors are doing the best they can with the resources that they have. And that includes the education that they have. I went through medical school in the early 2000s, as did a lot of the doctors that are out today. There's a generation older than us that practiced before the studies that I'm going to talk about. And there's a generation after us, which now is probably in this weird gray area, but still not being taught very much. Most physicians, though, are taught what the guidelines from the major organizations that have to deal with hormones say. So I put the 3 major organizations here. So ACOG, the Endocrine Society, and NAMS. ACOG is your obstetrician gynecologist, Endocrine Society is your endocrinologist, and NAMS is a menopause society. They all have recommendations about hormones. But for the most part, I can summarize those recommendations to say that they are aiming at the symptoms of menopause for women. And they have them for men too, but we're talking specifically about menopause. And the goal then is to use the lowest dose for the shortest duration. Now, from a health span perspective, from an anti-aging perspective, that doesn't really make sense because we know that the lowest dose that can improve the symptoms of menopause, which are feeling potentially, are usually not an adequate dose to actually have an impact on bone or some of the other things that we think that it'll do. And then the shortest duration part doesn't make sense to me either, because why would you ever stop? And that's a very controversial statement. But from an anti-aging perspective, I think of hormone replacement like I do, something that you can't get in diet that you're supplementing. Like almost all of my patients are on magnesium, right? Why would I ever stop magnesium? It's not going to magically get made in my body. So same thing with hormones as we age. We are not going to automatically start making them at some point. You either use them and benefit from them or you don't. The general consensus is that the long-term use risk, the risk of long-term use, outweighs the benefits. And this is written in every doctor book and manual that I've ever seen on the topic. And I've looked at a lot of them. And they talk about the risk of breast cancer, of blood clots, of cardiovascular disease, or having a heart attack. We'll talk about that. Estrogen by itself, and we'll talk about the differences here. There's an increased risk of blood clot and stroke. And the only benefit that they consistently will say that there is a benefit of is fracture prevention, because it's pretty profound, actually. So then we have to decide, okay, risk benefit, what actually makes sense here? So let's get into these hormones. So if you look at the blue and the pink on the right side of this picture here, you can see that the blue is male testosterone, and the curve is the amount of testosterone that a man has on average throughout his life. So you can see that it drops pretty significantly through the 30s, 40s, and then it just sort of slowly continues to go down. Now, this is different from estrogen in a woman, which I think arguably that this curve is actually not steep enough. Generally, what happens is women go through menopause, even though it might take a year, two, and sometimes more, but it is a rapid drop and loss of the sex hormone estradiol, and subsequently progesterone, and also to a less extreme extent, testosterone. And I'll talk about the significance there. So what happened before the 1990s is that we had the ability as doctors to either prescribe or have compounded to some extent hormones. So hormones were being used a lot. There were a lot of claims made about hormones, that it could extend your life and it make you feel amazing, and it reversed heart disease and, reversed dementia, and like all these crazy claims that were not science-based. So some research needed to be done, and that is absolutely true. And there was some research that was done. In fact, there was a lot of research that was done. One of the biggest trials that was done, that people talk about most frequently, and that most doctors will discuss with patients when they talk about hormone risk, is the Women's Health Initiative. There were others, but we're just really going to dig in here because all of the information you need to know and to be armed with is buried in this study. So the Women's Health Initiative was started in 1993. The publication we're going to talk about that changed the face of hormones was in 2002. This was a massive study, and it was actually pretty well designed for the most part. I mean, you could argue about some of the details, but really this was a big study. It actually had 5 arms. There were 160,000 women aged 50 to 79 enrolled in this study, obviously multiple centers, and it cost $734 million. People always ask questions about research, like, why can't we do a good study on this or on that? This is why. It cost hundreds of millions of dollars to do. And people argue too that this was not well done and it should have been bigger, and so it is hard to do studies on things like vitamin D, calcium, and exercise, that they actually had an arm in this study. They did a diet arm. It's one of the biggest nutrition studies ever done. I wish they would have done it on a different aspect of nutrition, but low-fat diet it is. And then they had HRT, and they had an HRT arm with a progesterone, and I'll explain this in a minute, but they had a progesterone and estrogen arm, and then they had an estrogen-only arm in women that had gone through a hysterectomy. So we now have the ability to compare 2 different types of hormone replacement.
Hey, Doug, real quick.
Yeah.
I noticed the left side of your screen is cutting off just a little bit.
Oh, really?
I don't know.
Oh, here, is that better?
Oh, you fixed it. Well done.
I fixed it. Sorry about that.
Right.
Yeah.
Continue. No, you're good.
It matters if it falls off my screen. Thanks for that.
No worries.
Yeah. So before we get to the results of this study, though, let me just define a couple of things. So in the 90s, there were some commercially available hormones. There are a lot more commercially available hormones now. But in the 90s, there were some. And as is usually true with doctors and pharmaceutical companies, if there is a commercially available product, they tend to use that product. We don't need to talk about why. I think for the most part, it's an honest use. But what they used in this study is what was most commonly used at the time, which is something called conjugated equine estrogen, CEE, and the brand name is Premarin. This is an oral estrogen product that comes from what's called mare's urine, or horse pee, is another way to say it. The reason why that's important is not because it sounds gross, but because mare urine is not the same as human urine, and mare estrogens are not the same as human estrogens. So we have this synthetic estrogen that has some estrogens in it that our body doesn't know what to do with. I have written down here 7. I've heard from vets that it's more than that. It doesn't matter. The point is it's more than what we have as humans, which is 3. And I just put this in here. We don't need to dig into this, but this is a human estrogen metabolism chart. And you can see across the top there, estrone, estradiol, and estriol. Those are the 3 primary human estrogens. And so we're in this study, we're using a synthetic product that has 7 or potentially more. And there might be implications there. And then I want to also point out this thing of progesterone and progestin. I hear these terms being interchanged as if they are the same thing. They are not the same thing. So prior to the 1950s, I put it in here. Prior to the actually, I didn't put it in here. No, I did. There it is, 50s. Great. So prior to the 1950s, progesterone as the bioidentical, if you want to use that term, hormone was made, but it was not utilized very often because it was not well absorbed. Not until the 1980s, when the pharmaceutical industry created the process called micronization, or making it really small, could we actually absorb the bioidentical form of progesterone. So the pharmaceutical companies made progestins. The one that they used in the Women's Health Initiative was called medroxyprogesterone acetate, or MPA, and that went by the brand name Provera. So you had Premarin and Provera, and together those 2 were called Prempro, and that was the most common thing used at the time. Progestins, though, really gained a foothold in the industry and are the majority of what you see in commercially prepared products. Progesterone as a natural product is available commercially, but it is more often compounded in the space that I live in. So this is the study that came out in 2002. And you can see that they are talking specifically about the risks and benefits of estrogen plus progestin. I'll explain why in the Women's Health Initiative. And I'll just read the important part of this conclusion, which is that the overall health risks exceeded the benefits from the use of hormones. What's interesting in here is that they even say very specifically about all-cause mortality. They talk about cardiovascular disease. And when you read this, you actually don't see the words breast cancer anywhere. And it's important to remember that what they were looking for in the Women's Health Initiative was actually cardiovascular risk and all-cause mortality. They were trying to show that there was not a cardiovascular benefit of using hormones. And so when you create a study around that, you should do the opposite of that, which is to prove that it's not true. And they did prove that it's not true. And while they were doing that, they found this concern about breast cancer. So let's talk about the concern about breast cancer. So in the Women's Health Initiative, the combined arm, which is the Premarin plus the Provera, or the estrogen and the progestin, together was stopped early. It was stopped early because of concern of increased risk of a few different things. They mostly talked about invasive breast cancer. There was also a concern for increased risk of stroke, heart disease, and blood clot. We'll talk about the statistics, and it made sense that they stopped the study because there were so many women in it, and the signal was pretty clear that they weren't going to get to the desired endpoint of controlling or reducing cardiovascular risk. However, what's interesting is that they didn't actually reach statistical significance of breast cancer either, or of the other things, or of stroke, or of heart disease. So when you go back and look at this study, and I've probably read this study, I don't know how many times, and looked at the data, it says very clearly on invasive breast cancer that it nearly reached nominal statistical significance, and nearly. And we'll talk about the opposite arm of that later, which also nearly reached something else. And of course, we've talked about this, and I've talked about this a lot in my videos, which is that they talk about relative risk increase. And so they cited here a 26% increase in the risk of breast cancer. Well, that sounds bad, right? And it would be bad, except that in a study this big, and something that's that, I don't want to say it's rare because it's not that rare, but something that is not that common, a relative risk increase of 26% is not that much. And you can see here that they had to do the statistics around the statistic of every 10,000 patient years, which is a legitimate thing to do, but you had to go out that far to have a big enough number that you could actually do the math. So 38 versus 30 per 10,000 patient years. And what does that actually mean? And for us non-statistical people, it's about 1 case per 1,000 women treated with hormones. Now, for that one person, they don't want to have that breast cancer case, and I get that. But the impact of saying that estrogen causes breast cancer resulted in a whiplash of women being pulled off, and men of testosterone, but mostly women being pulled off of hormone replacement, both combined, estradiol and estrogen only, overnight. I mean, millions of people essentially overnight. And then generations, I mean, decades of doctors unwilling to prescribe because of the fear for something that didn't reach statistical significance. I think that's pretty profound. What's interesting too, though, is that they showed that colorectal cancer and hip fracture did reach statistical significance. So there was protection, but that wasn't really talked a lot about. They only really talked about the breast cancer, or at least that's what I heard as I was going through medical school when this came out. What I heard was estrogen equals breast cancer, don't do it. And I said, I'm going into orthopedics, I don't care. And here I am. So 2 years later, the other side of this hormone replacement study came out. So I mentioned that there were two arms. There's the combined arm and the estrogen only arm. Now, the estrogen only arm was for women that had had a hysterectomy, so they didn't, quote unquote, need progesterone. I'll talk to you about why I think that's maybe not the right approach, but that's the traditional approach. So they were on estrogen only, and they did not stop it early like they did for the other one, or at least not that early. Now, they actually did stop it early, but not because of concern of breast cancer. They stopped it early because they knew that they weren't going to hit the threshold of demonstrating that there was reduced risk of cardiovascular disease, which again is what they were actually trying to prove. What's interesting here, the conclusion, I'll just read the middle part there. A possible reduction in breast cancer risk requires further investigation. I'm sorry, what? Did you say a reduction in breast cancer risk? Tell me that again. And so this was not touted. This did not make media headlines, as you could imagine. But essentially what happened was you had two studies, two arms of the same study, one that showed an increased risk of breast cancer and one that showed nearly a identical, or at least almost as significant, reduction in risk of breast cancer. And yet still the takeaway was estrogen causes breast cancer. It's really interesting. So again, as I mentioned, the impact of this is that most women were taken off of hormone replacement. It didn't matter if it was for symptoms of menopause or osteoporosis. If you really were struggling, you might find somebody to prescribe this for you. But what I hear from my patients over and over again is my doctor wouldn't even talk to me about it, which is really sad. Osteoporosis is actually an FDA indication for estrogen use, for estradiol use, but it is rarely used for that reason. And then all of the other potential reasons why someone might be on HRT, it was not being prescribed, at least in the majority of the population. So the impact then is that there may have been a reduction in breast cancer cases, because remember that 1 in 1,000 is real, but that's cancer cases. There are actually no decreases in death. Again, I don't wish that one cancer case on anybody, but what's the impact? Well, the impact for anybody who was on hormone replacement or should have been offered if it wasn't, is that they did not get that reduction in colon cancer. They did not get the improvement in osteoporosis and reduction in fracture. There was not a potential benefit for dementia, sexual health, depression, anxiety, metabolic health, all of those things, cardiovascular risk too, I should have listed in there. And the quality of life is really the biggest thing for me. Now, it's interesting when you look at the studies, they say that the quality of life was not different between people on and off of estrogen and hormone replacement therapy. Man, my patients would tell you otherwise. But what ultimately happened is, as osteoporosis became more known as an issue and the pharmaceutical industry recognized that there was a need, then they started creating these bone metabolism drugs. You guys are all familiar with bisphosphonates and other drugs. And they really gained a foothold in the market, and the use of hormone replacement therapy really fell away because everybody was afraid of it. And so now we have this landscape that we have now, which is you have I would argue, an overuse of the drugs for the vast majority of people. And you have an underuse of the potential tools of hormone replacement therapy, either through estrogen and potentially through progesterone and testosterone, which I'll talk about. But estrogen is the only one that's actually FDA approved for osteoporosis. Okay, so the three hormones, and men have all three of these too. So I'm just going to say this for everybody, and then we'll kind of split it up a little bit around men and women when it comes to the testosterone side. But estradiol is the primary estrogen in both men and women. It is the one that has the biggest impact, and it has the impact on bone similar to an anti-resorptive drug of reducing osteoclast function. We can measure this through the biomarker CTX, and we can watch it drop precipitously for someone who is on an adequate dose of estrogen. Testosterone, I'm going to talk quite a bit about testosterone today. Not as well studied in women.
And just for people remember, osteoclasts are the cells that help to you bone reabsorption, or will cause your body to extract calcium from your bone to put into your body. And so it's the cell that makes your bones weaker. Not a bad cell, it's just its function. And osteoblasts help to build up and create new bone.
Yeah. Thanks, Kyle. I sometimes
no worries. I know you
didn't cover the basics.
You get in the zone. It's okay.
Yeah. So, right. So osteoblasts then, like Kyle said, it's the opposite side, right? So osteoblasts are the building cells, and we never want to completely squash either one. As I mentioned in the beginning, it is a bone metabolism issue. So we want them both to work. And this is one of the challenges with the bisphosphonate drugs and the anti-resorptive drugs, is that they absolutely squash osteoclast function. And then you're building bone, but on top of debris that hasn't been cleared away. It's like trying to build a highway on top of an old highway that's broken down. It just doesn't work very well. It'll work for a while, but it doesn't work long term. So testosterone then also can be measured through P1NP, which is a biomarker that measures osteoblast function. Testosterone has the additional impact of increasing muscle mass and improving energy and a whole bunch of other things we'll talk about. Testosterone is a very valuable hormone for both men and women, and I'll get into that. Progesterone is also not as often talked about. It's usually just talked about because we have to protect the endometrium or the lining of the uterus when a woman is on estrogen. I think that it does more than that, because as you see in the literature, it actually also has an impact on osteoblasts. It will also improve sleep. So that's a big thing. It does balance estrogen in all the tissues, but I think that there are progesterone receptors on tissues outside of the uterus for other reasons. And I just think we just don't know what they are. So I think that even if a woman has had a hysterectomy, it's not unreasonable to consider using progesterone. So when do we start using hormones? And the answer is it's different for everybody. But remember that bone loss starts in their 30s and 40s for most people. Peak bone mass occurred even before that. So hormone dysfunction, as I showed in those charts, starts pretty early. Now, you're not going to do HRT for a woman who's still having cycles in her 30s, but you can still optimize hormones before then. And there is a role for having that discussion around what's missing, what can we do. Typically, we're going to do more along the lines of optimization and not replacement at that point, but understanding levels is really important. The benefits of considering estrogen replacement are many. And as I mentioned before, all the potential things that can go along with it. It's not just about bones here. It is definitely a health span play. The risks, we're going to talk about these. The cardiovascular risk, stroke and blood clots are kind of one together. And then any estrogen sensitive cancer is not just breast cancer, but all estrogen sensitive cancers are worth discussing. So then I mentioned before these two arms of the WHI and how the estrogen and progestin group came out first, and then the estrogen alone group came out later. The only risk that was increased in both was this risk of blood clot. And in one, there was a little bit of concern of heart attack, the other one stroke. It's the same foundational thing, which is blood clotting. We'll talk about why we don't necessarily need to worry about that. And then again, in the combined side, there was an increased risk of breast cancer, not statistically significant, but it was there. And then on the estrogen alone side, there was a decreased risk of breast cancer, almost to the same extent. So when you look at the list there, to me, it seemed very obvious that the thing that we should be concerned about is the progestin, not the estrogen. And yet nobody talked about medroxyprogesterone acetate, Provera, as the potential culprit here. Now I hear it all the time, but I think it's because of the world that I live in. But I think for the most part, people still view these synthetic progesterones, these progestins, as a safe molecule, and they are not, in my opinion. The risk of blood clot goes away. This is what this whole slide is about. It's very clear that the risk of blood clot goes away if you switch away from oral. And this specifically is about the progestins. I'm sorry, I went ahead of my mind. Sorry, this slide is actually talking about the increased risk of blood clot, but lower fracture risk. And this is just estrogen only. Sorry, I got too ahead of myself. Okay, so this is the transdermal part. So there are different ways that we can do hormones. There's oral, there's a few actually, but oral and transdermal are the most common, meaning you can take a capsule or you can use a cream or you can use a a gel or you can use a patch, but it goes through the skin either way. The risk of blood clot is there for oral, and I can walk you through the statistics here, but what I'm circling here is a statistical map, which basically says that anything on the left side of that dotted line vertically has a reduced risk of blood clot. Now, arguably, if the little purple horizontal line crosses the dotted vertical line, then it's not statistically significant. But for me, what this tells me is that if you use a transdermal product, you don't need to worry about the increased risk of blood clot. Now, you can see some of these. I think you can see my cursor. Here we go. So some of these have a significant increased risk of blood clot, right? And look at this one. Oh, it's medroxyprogesterone acetate. That's Provera, what they used in the WHI. Oh, that's a big number. So we can get rid of that concern of blood clot by using topical over oral. And then we also know in studies that have come out since the WHI that are looking at progestins compared to other things, progestins alone do demonstrate an increased risk of breast cancer, blood clots, mood changes, and actually osteoporosis. Oops. Even though progestins and estrogen are protective, progestins alone are not. And so this is something that I've talked quite a bit about. These are not molecules that you want anybody on. And unfortunately, they're in a lot of things. Now, oral progesterone, so oral micronized progesterone, brand name is Prometrium. Oral micronized progesterone does not increase your risk of blood clots. Now, we're in a bit of a gray zone because there has not been a large study like the WHI on oral micronized progesterone. As a bioidentical molecule, I wouldn't think we would see it, but I can't guarantee it. All right, so then let's talk about testosterone. Testosterone, I think, is really under-discussed in hormone replacement therapy. It is really only talked about in the world of hypoactive sexual desire disorder, which is an actual diagnosis. And it's available, but not really commercially in the United States. If I wanted to prescribe somebody this drug commercially, I couldn't do it because it doesn't exist. I'll talk about how we can get it. But here's what's going to blow your mind. So if you look at this chart, and I apologize, it's a little busy, but if you look at this chart, the solid black line and the black dot is testosterone. And this is in women, by the way. And the solid black line with the not solid dot is estrogen. E2 is estradiol. These are absolute numbers in the same units. Notice anything interesting here? That maybe testosterone is higher in women throughout the course of their entire life than is estrogen. And yet we talk about hormone replacement. We only talk about estrogen and progesterone. The primary sex hormone for women is testosterone. It always has been. It always will be. So why don't we talk about testosterone in women? This drives me absolutely bonkers. If you look at studies in men, because there aren't very many in women, if you look at studies in men, you'll notice some of the things that we desire for somebody that has osteoporosis: increased muscle mass, increased strength, increased bone mineral density. There was one study that even cited that BMD was greater than estradiol alone when compared together, back-to-back testosterone and estrogen. And of course, they're improved.
Bone mineral density.
Yeah, BMD. Yep. Thank you, bone mineral density. I need the starter course before we do this, Kyle. And then, of course, that last point is on improved sexual activity markers. And these are the things that it is known for, which is satisfaction, pleasure, and orgasm. And again, whenever I'm looking at drugs for health span, if we can find side effects that we like, then those are side effects that we can agree upon. And I think we can all agree upon those side effects for most people. Testosterone, then, as I mentioned, the primary sex hormone in women. And again, I'll just say that if you go to your doctor and they say, no, it's not, your testosterone, and for most people, it's not 40, it's actually like 4. Your testosterone is only 4 and your estrogen is 100. Look at the difference in units: picogram per ml, nanogram per deciliter. That's not an easy thing to do in your head, but Google and ChatGPT can tell you that that's a 10x difference. And again, hormone replacement therapy, nobody talks about testosterone, or very few people talk about testosterone. In women, testosterone is produced both in the ovaries and the adrenal glands. This is why after menopause, they may still have testosterone. But most people I see are stressed out about one thing or another, and their adrenal glands are too busy making cortisol, or they don't work at all. So they don't have any testosterone. What's interesting, and I actually showed this in that chart, I didn't really mention it, is another reason to consider testosterone replacement for women is that when you replace estrogen, it does two things that actually reduces the body's natural ability to produce testosterone. So even if you were making it, once you give estrogen back, you're probably not making it anymore. All those things that I mentioned for men, they're also true in women. And I don't know anybody who doesn't want those things: strength, bone density, energy, vitality, libido, and sexual function, all positives for most people. There are studies on all of the different hormones, and you can just see across the board, it is 3% for estrogen, 41% fracture reduction for estrogen. There are no good studies on progesterone and testosterone in bones, but the mechanisms make sense. And if you're going to do hormone replacement, I think you should do hormone replacement. So then the summary is, it does a lot of good things from a health span perspective, both estradiol, which we use as a topical, and there's a couple of different ways to do topical, and then an oral micronized progesterone is how I prefer to use it. It can be given topically, but I don't think it adequately opposes estrogen that way. And it helps with sleep if you give it orally. And then testosterone, we do it as a cream. I don't like pellets. I'll talk about how to get stuff in a minute. So then this is the question that I always get, and we probably have multiple versions of this question in the Q&A right now. What if I'm over 10 years out from menopause? Sorry, I spelled menopause wrong. Menopause. What if you're over 10 years out from menopause? And if you think about it, if you go the timeline of 2002 to now, we're 21 years after the publication of the Women's Health Initiative. Over the last 20 years, women have, for the most part, not been offered hormone replacement therapy when they potentially should have, in my opinion. And that includes the 0 to 10 and 10 to 20 years out from menopause group. So I get this question all the time. My doctor never talked to me about it. What do I do now? And it's a challenging conversation, because what happens is, I'm not concerned about the breast cancer side or the estrogen sensitive cancer side. What I'm concerned about is the cardiovascular risk. What the Women's Health Initiative did show is that in women that were over 10 years out from menopause, if they started on estrogen, there was an increased risk of cardiovascular event and stroke. Now, we know that there were issues because they also had blood clots, which leads to those things. I understand that. But that signal does exist. So what I'm concerned about for women that are over 10 years out is that, do they have significant cardiovascular disease? This is something we can look at, though. But we talk about their family history, their personal medical history. Have they been diabetic for 30 years? It's going to significantly increase risk. What are the risk factors working against them? And then we try to come to some understanding of the risk benefit. We know that they have osteoporosis. We know that they need to improve their bone mineral density and their bone strength. We know that hormones can help with that, but I do them no good if they have a heart attack or a stroke in the process. So it's a balance. And this is a one-on-one conversation that you have to have with somebody who's willing to prescribe in those circumstances. And most doctors do not prescribe 10 years after menopause. So that's hard to find. As far as the cancer question goes, for me, I keep reading literature that demonstrates to me that estrogen likely has very little impact on the development of cancer. If the signal is there, it is so small that the benefit will outweigh the risk. However, if you have an estrogen sensitive cancer, it will likely make it grow faster. Because breast cancer and other cancers that are estrogen sensitive are relatively, quote unquote, common. It's all relative, but they're relatively common. This is something that we have to deal with. But again, for me, I'm working with patients that I know have osteoporosis. So am I worried about the breast cancer that they may develop, or am I worried about the disease that I know that they have? And I would rather deal with the double that I know than the one that I don't know. But again, this is a balanced decision that you have to have with whoever's providing. And you have to come to a decision yourself because of family genetics, family history, personal genetics. There are a lot of factors that go into this. But for the most part, I'm not as concerned about the cancer side, because there are studies that demonstrate protection from cancer. So it is really a balancing act. But the 10 years after menopause thing is a bigger question. All right, so then how do we get it? So let me just run through this part and then we'll get into questions here. So how do I get hormone replacement? And here's the challenge. So the drug companies, as our drug companies, they like to make novel compounds, means new stuff that is not natural. Novel compounds can get patented. Patents make drug companies money. Estradiol is a naturally occurring molecule. OMP stands for micronized progesterone, oral micronized progesterone, that is also bioidentical and natural. Testosterone is bioidentical and natural. Drug companies don't like making things that are natural because they can't make as much money. I'm not saying it's a bad thing. It is just a business thing. So then we have to rely on compounding pharmacies. Compounding pharmacies can be both good, but they can also be bad. Quality really matters. So what I'm saying here is you got to work with somebody who knows what they're doing, can prescribe you what you need from a reliable source. And this can be a challenge. The second thing I see here is that there are no big studies on these more natural patterns of prescribing. So the way that I prescribe it, there has not been a study like the WHI, and there never will be, because nobody's going to make enough money to fund it. And so we have to kind of live in this gray space and do the best that we think that we can. What about my OBGYN? Well, as I mentioned in the very beginning, ACOG, the American College of Obstetricians and Gynecologists, they do support the use of hormone therapy, but only for the symptoms of menopause. And again, lowest possible dose, shortest possible time, not going to have a significant impact on your bones. The typical approach that they're going to use, I see this all the time, them using oral birth control. Not enough estrogen, for one, and two, it has progestins in it. So oral birth control is not hormone replacement. It's not the same thing. Estradiol patches can work. They usually come in low doses. They just have to be dosed right, but they can work, and they're commercially available and insurance will cover them. So that is a reasonable option. I always measure estradiol levels, and most doctors in the OBGYN space are opposed to measuring because, again, they're just going off of symptom relief. Progesterone capsules are going to be prescribed only if the woman has a uterus. Again, I think that there are reasons to prescribe them otherwise. There are combined products, so estrogen and the progestins, that can be delivered through a patch or also through a pill. And again, those are things that I would avoid because of the progestins. And then your OBGYN is unlikely to recommend or prescribe testosterone unless you go down the sexual health pathway. And then they might, but then they have to prescribe it from a compounding pharmacy because there's no commercial product. So you can kind of see the circle that you have to run in. So then let's say you want to get outside of the traditional medical system and you go to a hormone clinic, because every city has a lot of these. Well, if you do that, you might get exactly what you need. And there's variable service in these areas. Generally, they're going to use pellets. Pellets can have estrogen and can have testosterone. Sometimes they only have testosterone. The problem I see with this is that they use really high doses, which can have higher complication rates or side effect rates. You can't get it out. So once that thing goes in, you're on a ride for the next 3 months. And I've seen some women have some really bad side effects from them, and they're really unhappy, and then they're afraid to use them. They can be done right. I just think that oftentimes they are not. They often are not testing either. They're not doing blood tests either. If you want to look for physicians trained by the same fellowship program that I went through, A4M, that's a reasonable place to look. So again, A4M is the anti-aging, American Academy of Anti-Aging Medicine. And so they have a list of providers that have gone through that training. They may or may not prescribe hormones though. So you still have to ask and see what their practice is like. When to start? Everyone's different. We have premenopausal women that are on testosterone and progesterone. We have perimenopausal women that are on those two and potentially a very small dose of estrogen. Postmenopausal women, if they can be on it, they're on it. Men, this is a whole different conversation. Men starting younger and younger because average testosterone levels are plummeting like a rock in a lake. So men, it's really important to diagnose low testosterone early and then either get it optimized or get it replaced, because it will have an impact on your muscle, bone, and lots of other things. So in conclusion, you really need a comprehensive approach. As I said in the beginning, this is a tool. It is not the only tool, and it is a relatively big, subtle approach, if that makes sense. It's a big one. It just shouldn't be the only one. For resources, I have a couple things I'm going to mention here. From a resource perspective, we're actually just now launching our new website, which will have more resources on it, but optimalbonehealth.com is a resource for that has free content on it. The book that Kyle mentioned, you can download this book for free. This is the one that I wrote recently, and I consider it like a jumping off point for those that are new to the diagnosis of osteoporosis or not making the progress that they want to make with osteoporosis and improving bone health. And so you can go to this link, optimalbonehealth.com ebook, and you can download the book yourself. It's also available for purchase on Amazon if you need the physical book. And then this isn't the time and place for it, but if you want to talk about our program, these are the people that you need to talk to. And again, same website, just schedule and you can chat with our team. I don't want to spend any more time there. If you're looking for resources from a social perspective, our YouTube channel has a lot of content on it. The interview with Dr. Jaquish is on there. And I'm also active on Instagram and Facebook, but mostly Instagram. And then lastly, there's too many things, but lastly, if you're looking for another avenue to ask questions to somebody like myself or a team member, if you go to our other platform, Optimal Human Health, look for the thing called HealthSpan Nation. We're actually launching this soon, so it's not really ready yet. You can sign up for a wait list, but this is just another avenue. It's a resource for Q&A style presentations that we're going to start doing outside of our own patient care. So just another thing to consider down the road. And that's it.
Listen, thank you so much, Dr. Lucas. I really appreciate this. We're going to jump into some questions. There are a lot of them. Most of them are ones that you should probably be answering. I could answer some of these, but I would also be curious to hear some of your answer. And I want to thank you for, if you want to quit sharing your screen so we can see your face. I want to thank you for coming on here and tell everybody, look, if this is something that you're concerned about, you're interested in, Dr. Lucas is not paid to be here. This is information we want you guys to have. And so if this is something you find helpful, that you're seeking a resource, please reach out to his clinic and communicate with them. I think he's a wealth of knowledge that will definitely help all of you guys. I look at longevity as a whole, and bone density and strength and balance are just part of that. Osteostrong is probably the most powerful tool, but he said he called Osteostrong as foundational. I look at it as 3 overlapping circles. You have to have nutrients, you have to have proper hormones, and you have to have proper stimulation. Osteostrong is probably the most powerful, but if you don't have your hormones aligned, and you don't have your nutrients aligned, it doesn't do as well for you. But when you have those things in line, the research is going to show here very soon when we publish our studies that really nothing is building bone density even close to what Osteostrong is doing. So we are really happy and excited to be partnering with Dr. Lucas to get this information out to everybody. But enough of me. You have access to the questions there as I do. And there's not a huge number of them. You'll see some things going on. If you want to just start and kind of go through some of these.
I can do that. I think too, I don't know if you can see it up there, Kyle. There is a participant from my team on here that could actually, I think she was taking notes. I don't know if you're going to be able to find her though, out of the 300 something people that are in there. So her goal was to be able to say these live, but I think what we'll do is probably
I couldn't activate the I don't know if she,
yeah, it's okay. I can read too. So let's see here. So here is these are questions about bone density. I'm going to talk about the hormone questions.
Yep.
Oh, here's a good one. So this is a question for men. So Perry was asking about men and prostate issues. Testosterone is a growth factor for boosting, will promote prostate growth. Great question, Perry. And I actually left off the 2 slides on testosterone risk for men because obviously prostate issues aren't relevant for women. But there's a new study that came out recently, a 2023 publication that really helped to answer the cardiovascular risk or the heart attack risk around testosterone. And the answer was, in an intervention trial, reasonable dosing, there was no increased risk of heart attack with testosterone. This was obviously all in men. The prostate issue is more controversial than that, as is, it seems like, every conversation around cancer. But here's my conclusion after doing a lot of research on this, which is that testosterone deprivation in the face of prostate cancer. So if someone has prostate cancer and you chemically castrate them, which is a terrible word, but that's what it is. If you chemically castrate a man, they have absolutely no testosterone, their cancer will shrivel and die. Usually requires some additional treatment, radiation, surgery, whatever. But here's what's interesting. If you give a man with prostate cancer testosterone, it'll shrivel and die. Interesting, right? So when you start to have to read between the lines and you look at what is testosterone really doing to prostate cancer, for a man that has low testosterone, like really low testosterone, and you give them testosterone, it will increase their cancer growth temporarily. But there's a saturation point, which is at a pretty low level that most men should be above anyway, that once you get above that level, there's no additional issue with prostate cancer and testosterone. So what we're seeing now is we're seeing men that have prostate cancer being given testosterone. We're seeing men that have had prostate cancer being given testosterone. Now, this is not commonplace, but this is the space that we're pushing into because the smaller studies are showing that there is the ability to provide men this benefit of testosterone after having had treatment for prostate cancer. Is there a risk of it coming back? Sure. But there was already a risk of it coming back. And the men that I know that have been through the treatment of chemical castration, it's not fun.
No.
So yeah, so it's a challenge. Yeah, so what are the recommendations? This is from Jeanette. So what are the recommendations for those who have had breast cancer regarding taking hormones? There's actually a similar conversation with prostate cancer in men. So the usual answer is if you have had breast cancer, then you are not a candidate for hormone replacement, just across the board. And in the traditional medical model, most physicians lean on the conservative side of the risk-benefit equation, because if there's not a lot of perceived benefit, then if there's any risk at all, they don't want to do it. However, we know for someone that has osteoporosis, which is very common after breast cancer treatment, for someone that has osteoporosis, there is benefit of being on estrogen. There are other benefits too. And so the question is, can a woman who really wants to take estrogen as hormone replacement therapy after having had breast cancer? And the answer is maybe. So it depends on the type of breast cancer. It depends on the particular sensitivity to estrogen, progesterone. This is a team effort. So this really, for us, we have some patients in this boat. It requires going to the oncologist or potentially the onco surgeon and having this discussion. And then generally they're going to say no, but if you really feel strongly, the risk is up to you if you can find somebody to prescribe it. And then they come to me and they say, will you prescribe it? And it's a tough decision because breast cancer recurrence is pretty high. So what's the likelihood of somebody getting a breast cancer recurrence if I give them estrogen? Well, it's still pretty high. So again, it's very, very individualized, and it comes down to what kind of breast cancer it is, how bad is the osteoporosis. It's that risk-benefit equation, but it's really tough. Tough question to answer. Here's a question about are estradiol patches synthetic, from Angie. And the answer is, so that's funny, synthetic and identical, bioidentical, natural. These are all kind of funky terms around hormones because anything that's coming in through a patch is clearly synthetic. It's been created in a lab, but so did bioidentical hormones that are coming in through a cream. And so they're just different ways to give the same compound. So estradiol is the bioidentical molecule, if that's what you mean. And yes, patches can have estradiol in them, but be careful because it can have other stuff in it too. Testosterone only comes through a cream. This is the other side of this here. It can only come through a cream for women for the most part because the forms that are available for men are going to be at too high of a dose. And so Angie mentions testosterone injections. Testosterone injections are going to be usually, well, almost always that I'm aware of, available for doses made for men. So you're talking about a 10 to 20 fold increase in strength compared to what you would need as a woman. So the likelihood of you getting too much is really high if you were to do an injection. And then similarly, pellets can or may not be too high. Great question about measurement here. So there's a question by somebody anonymous, but they ask, should hormones be measured by saliva, blood, or urine? And it a little bit depends on how you're taking them. The gold standard is blood, always blood. So if there's any question, use blood. If you're using something like a transdermal progesterone, you can't measure that in blood. But the way that you measure it in urine and saliva is, it's been studied. But I'm not comfortable as a physician knowing that either of those, if it's normal, is going to be enough to offset the potential risk of estrogen, even though I think there's not as much risk. But there is case law that actually would demonstrate that because you can't test progesterone topically, that you should not use it to offset the role of estrogen. So blood, always blood.
I will say there is one, somebody asked here about thyroid, and it's actually one of the most common reasons why we see people get less than optimal results at Osteostrong is hypothyroidism. And so thyroid being a hormone as well.
Sure.
So I would recommend people get that hormone level checked as well.
Yeah, thyroid is that would be, it's a whole fun topic. But
yeah, I didn't want you to go rabbit trail on that too much.
Low thyroid is an issue, but over treatment for low thyroid is also an issue. So that's something that's just got to be dialed in. Here's a good question that I hear a lot. So what if someone is taking an estrogen blocker? So this is really common for breast cancer treatment or the prevention of recurrence. And so this is a scenario that I worry about women not understanding the implications. Because if you're on an estrogen blocker, it's like going through menopause, but rapidly, because it really shuts down all estrogen. So you will see all of those risks that occur with menopause over the course of years. You'll see them starting day one of starting that drug. This is the situation, especially if this is going to be a temporary thing, like you're going to be on an estrogen blocker for a couple of years, and you've been recommended to take a bone drug like a bisphosphonate or Prolia. This is the only circumstance, in my opinion, in which that actually makes sense. Because yes, there's risk of the drugs, and no, I don't like them, but there is risk of having estrogen ripped out of your body as well. And so this is the only scenario where I say, make sure that the risks and benefits for you are for you, and you're not talking about what your neighbor or somebody else on the osteoporosis Facebook group is talking about, because they might not be on the same drug and might not be in the same situation. So that's a really important one that I don't want women to forget about, because when they do 3 years later, you know, they've had massive loss in bone mineral density and bone quality, and they're at high risk of fracture.
What blood tests do you recommend people get, and where should they go get them? I know that there's a lot of clinics you could just walk in and order your own blood test now, which I know that I've done a few times.
Yeah, so it's getting easier to do direct to consumer, and LabCorp and Quest both have that ability. I've found though that the easiest way to do it is I'm blanking on the name of it. Life Extension, actually. So Life Extension as a company, I think, has the best direct to consumer labs. That you have to figure out where to get them done. Depending on how rural you are, that might be a challenge, but they have the most options. So the tests that we run, if I can do this off the top of my head. So estradiol is the estrogen that you want to know what the levels are in blood. To understand then what's happening elsewhere, you want to know your testosterone, and you want to know total, but you also want to know free. And there are a couple of different ways to do that. But if you just look for the word free, then you'll know that you're getting total and free. We also measure SHBG, and this is important, more important for men, but still important for women too. SHBG stands for sex hormone binding globulin. And then progesterone in blood, you can measure. It's kind of hard to capture progesterone in blood in general, but again, it's the gold standard, so we always measure that. If you're getting those things, you can get a sense of what's happening with your hormone replacement. Most doctors that, especially in the OBGYN space, are not going to order those labs because, again, they don't know what to do with the results, and they ultimately don't care about the results because they're going after symptom relief, not about the things that we're talking about.
Yeah, you can go like into LabCorp or any blood test is like you get an appointment and go in and get and order those blood tests yourself. Now, the good news about getting those blood tests is it will tell you on your results on the report what normal range is and where you fall within that report. I wouldn't rely exclusively on that. I would get the results or contact like Life Extension or Dr. Lucas and have them review those results with you, because there might be an opportunity to go get a more extensive blood test. If you're going to go get a blood test, you might as well get a full battery. It's more expensive, but it's going to give you the best visibility into where you are across the board. And so you do want to know your hormone levels. That's important, but there are so many other things that you could look at too. And talking to a guy like Dr. Lucas or doctors at Life Extension or Life Force, which is Tony Robbins' company, they do that too. They sent a phlebotomist to my house on my schedule, and it was it wasn't that expensive.
Yeah.
And then you get to go meet with a doctor like this. So I highly recommend doing that. I try to do that every 3 to 6 months. I'll take a look at my my blood work just so I have an idea of my baselines, what I need to adjust either for supplementation or if I'm not eating properly or whatever. I want to know those numbers.
Yeah. Yeah, no, that's great. And I'm glad you mentioned the reference range thing. I'll say it a different way to drive that home, which is when you get those labs from LabCorp or Quest or wherever, they're going to have the reference range listed. That reference range is a statistical average, not optimal. And so if you imagine what those numbers are going to be for a postmenopausal woman, estrogen goes to 0, testosterone goes to 0, progesterone goes to 0. So the reference range includes 0.
Yeah, it's kind of like recommended daily allowance on vitamins. It's not really optimal.
It's definitely not optimal.
It's the amount that you need not to die.
Arguably not even that.
Yeah. Or in some cases,
it is a slow death. Yeah, exactly. Yeah.
I know that there are a lot of questions. If you just want to cherry pick one or two more,
sure.
And then go ahead and wrap it up, because there are
this is a good one. People ask this a lot. So a lot of times, women will be put on a vaginal type of replacement, either a cream or an IUD, so a device that goes into the uterus itself. And the intent behind there is to provide local hormone replacement. And this could be progesterone if it's an intrauterine device. It can be estradiol if it's for the vaginal mucosa. But I hear all the time, well, doesn't this protect my bones? And it is possible to absorb enough estradiol through that mucosa to protect bones, but that's not generally how it's prescribed. And so generally the way that that's prescribed, it is going to be for local administration only. It's going to help that specific tissue and issue, but it's not going to be for bones. So don't be fooled to think that you're protecting your bones by having that kind of hormone replacement therapy. And
what thyroid test would you think would be most optimal?
Great question. Yeah, sorry about the slides being off center there. I see a couple of questions about that. I just had it a little bit off my screen. So thyroid tests, really important to get the full panel of thyroid tests. So most doctors will get a TSH, which stands for thyroid stimulating hormone, and that's it. TSH tells you something about your thyroid axis, but potentially not a lot. What I really focus our treatment on is the free thyroid hormones. So free T3 and free T4. To make decisions about treatment, you also need total T3 and total T4. And then I also like to get reverse T3. It actually helps me more from an adrenal perspective, but it can help us to understand where some of that T3 is going. And then especially if it's the first time I'm seeing a patient, I want to know about the antibodies. So TPO antibodies and antithyroglobulin antibodies, because autoimmunity against the thyroid is really common.
Yep. Thank you.
Yeah. Yeah, let's see here. Lots of drug questions. Those are all the ones that I saw. Yeah. Okay. Well, I think we actually did it.
I think we actually did most of them. So thanks again, everybody, for coming in into the group today. And thank you again, Dr. Lucas, for coming in. We really appreciate it. A lot of these things I know, but every time I talk to you, I learn something new, and iron sharpens iron. So I'm a fan. I hope everybody got something out of it. We will look forward to feedback and other webinars and experts that we could bring in, whether it's Dr. Lucas or somebody else. He knows a lot, but he doesn't know everything, and neither do I. So we'll always try to bring in an expert to answer questions. So if we're getting a lot of consistent questions from everybody, we'll always seek to do this going forward. So look for us about once a month for now, and then we'll get you guys better information. So thanks everybody for coming in. Thanks again, Dr. Lucas. I really appreciate you.
Thanks, Kyle.
And
appreciate
everybody. Have a great evening.